all of you. Okay, so as you might know, that I'm Dr. Jabeerah Munir, one of the mentor of MedPrep Online, who's teaching part 1, MRCPCH part 1. And today I'm here to talk about the guideline updates. As we all know that they have been issued 2025 guidelines, and we haven't received the bedside guidelines yet, although neonatal one has been published, but not the other ones. So those guidelines which need to be focused on for the part 1 exam, we are going to discuss that today, and we are going to discuss about the important changes that has been occurred. Okay, so we are going to cover that, and that's let's go through them, that what we are going to discuss today. Okay, so today the guidelines which we are going to discuss will be asthma mainly, because they have been changing asthma guidelines quite multiple times, and we have a lot of questions in our exam coming in FOP and TAS exam related to the asthma. Even we have this guideline in the clinical cases as well, but those clinical cases are very like it's about 2017. Yes, so it's not the recent one, so we do not need to follow those. After that, we have been going through multiple guidelines, but now recently they have changed the guideline of the asthma, and that has been occurred in 2024. Now the bedside guidelines previously was 2022 and 2024. In that also they do not have the updated guidelines. Okay, so it might be present in the 2025 one. So that is the reason why I have come here to tell you the changes, so that whenever you come through the questions of the asthma, so you should know that what are the changes has been occurred, and you have to answer them accordingly, right? So we are going to discuss about asthma management under 5 years of old. Okay, then we are going to discuss about asthma assessment and management for 5 to 16 years old. So because I haven't mentioned assessment over here, because before 5 years of old, the assessment is on the clinical basis. Okay, but for 5 to 16 years of old, they have given a pathway for the assessment in 2024. So we are going to go through that. After that, we are going to discuss about the post-exposure prophylaxis for varicella and shingle. So this is also one of the guideline which has been changing quite multiple times, and now recently they have changed in February 2025, which I haven't seen anywhere else, but it is present on the government website. So I have taken the important box from that, which you should focus for the FOP and TAS exam, and you should answer them accordingly, because a lot of questions are there in the exam for the post exposure prophylaxis of the neonates especially. So we are going to go through that today, and in the last we are going to talk about the diabetic ketoacidosis, the whole guideline we are going to discuss. Although there are no recent changes in the diabetic ketoacidosis right now, but the one which is given in the bedside guideline has some confusion, which makes the student confused regarding the bolus solution, regarding the maintenance fluid. Okay, so we are going to cover this guideline accordingly, that what should be given and what not, and what is asked in the exam, so that you have a thorough knowledge about it. So that I have taken from BSPED, which is most likely the NICE guideline, and we are going to discuss that as well. Okay, so let's get started. Okay, so first we are going to discuss about asthma diagnosis or assessment, which is recommended in 5 to 16 years of age. Okay, so the test which is recommended for the asthma diagnosis, that first line test, they say that to do the fractional exhaled nitric oxide test. Okay, so actually this nitric oxide is present in our lung and we exhale that. So that is monitored, and looking at the value, we decide that whether it is normal, whether it is intermediate, or whether it is severe, or it is at the level at which the asthma can be diagnosed. So when we do this FeNO, that which is the fractional exhaled nitric oxide, we see the level. So if the level is 35 or more, which is 35 or greater than 35, then it is suspected that the diagnosis is asthma. Okay, so if it is coming 35 and more, yes, then we are going to ask about the history. And if the history plus the exhaled nitric oxide is suggestive, then we go to the diagnosis. Then that with history, it is suggested of the asthma, and there is a confirmed diagnosis. Okay, now, if it is not coming positive, that means it is not coming 35 or greater than 35, or it is not available, then we move to the second test, which is the BDR test, and that is bronchodilator reversibility with spirometry. Now, in this test, what we do, that we check the baseline spirometry, and that is the pulmonary function test. Okay, and then we give them certain bronchodilators, inhaled bronchodilators, and after some time, approximately 10 to 15 times, uh, 10 to 15 minutes, we check again the pulmonary function test spirometry, and then we check whether there is a improvement or not. Okay, so depending on the improvement, because if it is asthma, right, so there will be certain degree of improvement with the bronchodilators. If it is not, then it is least likely that it's asthma, right? So that is why we do this test. So bronchodilator reversibility BDR with spirometry, we do this. So what we are going to see, if it is suggestive of asthma, so we see that, is there reversible airflow obstruction 12% or more from baseline? Okay, that means if there is any improvement, is there any reversible changes of the airway obstruction? And then we have to see whether the improvement is 12% or more from the baseline spirometry we have taken, or we are if not if we are not comparing with the baseline, then we have to compare with the normal values. So for the normal values, we are going to see that whether there is 10% or more of the predicted normal value. So if it is yes, and if it is improving, so that means that this is suggestive of asthma and diagnosis is confirmed. Okay, if it is not improving, okay, then we directly switch to the last test. Okay, and this is basically a skin prick test or total IgE and blood eosinophils, in which is there evidence of house dust mites. Okay, sensitization. House dust mite sensitization is like dust allergies and all that. On skin, we are going to check on skin prick, or is total IgE raised. Okay, so is there evidence of house dust mite sensitization on skin prick? So we are going to check the skin prick test for the sensitization of the house dust mite. Okay, or we are going to check the total IgE raised or not. Okay, so if there is evidence of sensitization, like if it is coming positive, skin prick test is coming positive for the house dust mite, then this is suggestive of asthma. So diagnosis is confirmed, right? If it is not, okay, then consider alternate diagnosis. Now coming to the total IgE, if it is raised, okay, then is eosinophil count more than zero point 0.5? Okay, so we have to see that whether the IgE raised or not, and whether the eosinophils raised or not. Okay, so if it is raised, then we are going to talk about the eosinophil count. So eosinophil counts, if it is not raised, then refer to a pediatric specialist for a second opinion and consider bronchial challenge test. Okay, and if it is yes, it is increased, so this is the highly suggestive of confirmed diagnosis of asthma, right? So two cases. If yes, BDR positive, then we are going to see this. If no, then we are going to move towards this. If there is, it is not available, like if BDR is not available, okay, or it is delayed for some reason, then we are going to move towards the another test, which is peak expiratory flow variability. Okay, so peak expiratory flow variability is, we have a meter, which is the peak expiratory flow rate meter. It is used when the person is suspected of asthma, and we give them and they blow into it, and we check its rate. Okay, so we take the 3 times we take that, and we are going to take out it mean, and this will show us the variability, right? So depending on this test, we are going to see is amplitude percentage mean 20% or more. Okay, so the normal value of the peak expiratory flow variability should be less than 10. Okay, between 10 and 20 would be the intermittent thing, and if it is 20, like mean 20% or more, then this is highly suggestive of asthma, and that the diagnosis will be confirmed. Okay, then coming to the another test again, which has we have already discussed when we did this one, that is skin prick test or total IgE and blood eosinophils. Okay, is there evidence of house dust mite sensitization on skin prick, or is total IgE raised? Then depending on this, we are going to suggest that whether the asthma confirms the diagnosis or not. Okay, do you have any questions up till now? If when I am teaching you, okay, explaining you, if you have any query, you can put in the chat box, or you can speak as well whenever you want, so I can answer you. All right. Okay. So this was regarding the assessment. Okay. Now we are going to talk about management, which is very, very important for FOP, especially. Okay, so guidelines usually don't come in TAS exam. It is more important for FOP exam. Guidelines are solely for FOP exam. Okay, so there is a quite change in the asthma management. They have changed in 2024. Okay, and it's not present in the bedside guideline 2022 from 2024. We are still waiting to for 2025 guidelines. Okay, maybe they have this thing in them. So yeah, so coming to the management, that how we are going to manage the asthma in children who are from age group 5 to 16 years old. Okay, so if the child is has been assessed, and we come to know that child is already diagnosed as asthma, all right, we are going to start the child on the pediatric low dose ICS, which is inhaled corticosteroids. Okay, so we are going to offer them twice daily pediatric low dose ICS, all right, with a short acting beta agonist. All right, so we have to start the two things, which is the offer twice daily pediatric low dose ICS with a short acting beta agonist. Now, this is a reliever therapy, short acting beta agonist. When the symptoms appear, we give this. And this is a baseline, which is a maintenance therapy, which is the pediatric low dose ICS. Now, we are going to start this. All right. Now, when we are going to start this, we are going to see that whether the asthma is being controlled or not. Okay, how you're going to see that? Even in the scenarios of FOP, what you're going to looking for is that how you're going to know that it's being uncontrolled. So the point you have to see is over here, uncontrolled asthma. Any exacerbation requiring oral corticosteroids, that means it's so severe that they reaches to the ER for the oral corticosteroids, or frequent regular symptoms such as using reliever inhaler 3 or more days a week, or nighttime waking 1 or more times a week. So simple as that. You have to remember two things. Okay, that if they are having um, 3 times per week symptoms in a day, okay, or 1 time in a week symptoms in night, okay, or they are directly rushing to the ER for the oral corticosteroids. Okay, so in this way you are going to suspect that this is an uncontrolled asthma, right? Now, if it is uncontrolled on this ICS, low pediatric low dose ICS with short acting beta agonist, okay, then you have to assess the child whether they can take the MART regimen or not. Now, what is MART regimen? MART regimen is basically maintenance and reliever therapy combination, which is given through the inhalers, right? Okay, before that, I come to this, I want to show you a chart which is provided by the NICE about the steroid doses. Okay, so I have another chart over here. Yeah. Okay, so we were talking about the low dose steroid. So low dose steroids are here, pediatric low dose steroids. So they have 100 to 200 microgram, 100 microgram. So depending what type of inhalers we are using, or what type of particles we are using, so it's about 100 to 200 every time, 800, 80, 100 micrograms. So depending what we are using. So up till now we have used this one. Okay, so this I have just put this box just to show you that what they have provided about the doses, right? Okay, coming back to our guideline. Now, assess ability to manage MART regimen. Okay. Now, what we are going to assess basically, we are going to assess that whether the child knows how to take the inhalers, whether the child knows when to top up and top down. Okay. Are they adherent to it? Can be they adherent to it? Okay. Whether mother helps them or not. So we have to assess a lot of things. Okay. If they are able to manage the maintenance and reliever therapy, okay, then what you're going to do, you are going to follow this chart. Okay, so consider pediatric low dose MART. Now MART contains long acting beta agonist, which is the fast acting long acting beta agonist, and maintenance therapy, which will be low dose ICS. Okay, so pediatric low dose MART therapy. Okay, then you're going to see again, look the child about the symptoms, whether it's control or not. If it's not control, consider increasing to pediatric moderate dose smart. Okay, so moderate dose, again I will come to the moderate doses, okay, of the ICS, like 300 to 400, 150 to 100, 300 to 400. These are for the ICS one. Okay, so these are for the inhaled corticosteroids, right? Okay, then if it is again uncontrolled on this, refer the child to a specialist and asthma care. Now, one point they have mentioned over here, in November 2024, no asthma inhalers were licensed for MART in children under 12 years of old. So they mean to say that although it is not licensed, okay, but it can be used unlicensed. Okay, so off label, not unlicensed, but it can be used off label. So the use of it would be off label. Okay, since November 2024 they have made these changes. However, they are not going to ask you this thing in the exam. All right, the main thing you have to follow is this chart basically. All right. Okay, where were we were over here, that we have to see whether they can manage or not. So if they can manage, we are going to follow this, and if they are unable to manage, okay, then we are going to follow this chart. Now this is quite similar what we used to do in the previous guideline. Okay, so what it says is, consider adding an LTRA, which is the leukotriene receptor agonist, um, which is Montelukast, to twice daily pediatric low dose ICS inhaled corticosteroids for a trial period of 8 to 12 weeks. Okay, stop if ineffective or side effect, along with the short acting beta agonist. Okay, so that means, like, if they are not using MART regimen, okay, then you are going to continue this low dose ICS, and along with that you are going to add the Montelukast LTRA on that. This LTRA should be used as a trial for 8 to 12 weeks, and you have to assess that whether it has any effects or not. Okay, if it is ineffective, okay, or the asthma is not being controlled on it, it's if it's ineffective, if there is side effect, then you have to stop the leukotriene receptor and agonist, and then you are going to continue with the low dose ICS with the SABA only. Okay, and then you have to see that if the asthma is uncontrolled or controlled. All right. Now coming to the next step, it says that offer twice if it is uncontrolled, like if asthma is uncontrolled. All right. So offer twice daily pediatric low dose ICS LABA, which is the long acting beta agonist combination, with or without an LTRA, depending whether it had a response or not. Okay, so that is written, it's clearly written in the NIC guideline website. Okay, that you have to see the response of the LTRA, Montelukast, okay, that whether it is being responsive or not. If it is ineffective, completely ineffective, or side effects is there, we are going to stop this. Okay, if it is being responsive, you have to continue with this. Okay, now being on the low dose ICS and LTRA, if the asthma is uncontrolled, okay, then you are going to top up this low dose ICS and LTRA with the long acting beta agonist. Okay, so that means either you're going to give three things, which is the low dose ICS LABA along with the LTRA. Okay, if the LTRA was responsive. All right, if it wasn't responsive or it has any side effect, then you're simply going to cut off the LTRA, and then you're going to continue with the pediatric low dose ICS and LABA with combination of the SABA. So here we are going to give the short acting beta agonist as well, long acting beta agonist as well, and low dose ICS as well. Right, then we are going to assess the child, and we are going to see the symptoms, whether the child is improving or not, or they are having 3-day symptoms or one night symptoms. If it is so, then you're going to come to the next step. Now what will be the next step? Offer twice daily pediatric moderate dose, okay, ICS LABA combination with or without an LTRA. So same thing follows over here also, but only the ICS will be top up with the moderate dose. Okay, so the doses I have already shown you in the next box. All right, so all the steps remain the same. If it is still not controlled on the pediatric moderate dose ICS LABA combination with or without LTRA, then you are going to refer the child to the specialist in asthma care. Okay, so that's it. It's enough to do up till here. This is the guideline which they have given, updated guideline in 2024 for 5 to 16 years of age. So in FOP exam, you have to look for the age group, what they are talking about, and then you have to guide accordingly. Bear in mind then that whatever questions are has been coming if related to the asthma in the previous recalls, it's useless to follow them because it will create a confusion between you, because there will be options which will make you confuse. Obviously they are not going to give you such questions which make you confuse, because it was related to the guidelines which was previously discussed. But now as the guideline has been changed, there will be new questions related to this. You will be having new options related to the guidelines, okay, which will not make you confused. So remember this guideline, okay, and then answer accordingly. No need to follow the previous recalls of the asthma because they are according to the previous guideline. Okay. Any question up till here? Okay. Okay, now we are going to discuss about asthma management under 5 years. Okay, so this is also has been changed in 2024, right? So they say that, like, if children under 5 with suspected asthma and symptoms indicating need for maintenance therapy, which is the inhaled corticosteroid, or severe acute episodes of difficulty breathing and wheezes, then what you are going to do? So obviously, because under 5 years of age, it hasn't been properly diagnosed. We do it by the clinical basis, looking the clinical symptoms and how often they are using the dilators and the maintenance therapies. So children under 5 with suspected asthma and symptoms indicating need for maintenance therapy or severe acute episode of difficulty breathing and wheezes, if such children come to you, what you're going to do, you are going to start a trial of low dose ICS. Okay, so of low dose inhaled corticosteroids, you're going to start. So consider 8 to 12-week trial of twice daily pediatric low dose ICS with short acting beta agonist. Now, this guideline is for under 5 years. Remember this thing. Okay. Now, you are going to assess the child throughout this 8 to 12-week trial of the low dose pediatric low dose ICS with a SABA. Okay, if the symptoms does not involve during this trial, so there could be certain reason that why it's not being controlled. Okay, so what you're going to look for then, that if it's not being controlled on this low dose ICS with the SABA, so you're going to check inhaler technique, that either they are taking a proper mask with the inhaler or not. Okay, whether their technique is okay, whether they are taking inhaler correctly or not. Okay, adherence, you're going to check the adherence, that whether they are taking it on time or they are missing the doses, whether there is an environmental source of their symptoms, like dust, anything which causes the symptoms to, smoking, this kind of things, that even on these doses there is a triggering factors on in their environment which is not being controlled. And then review if any alternative diagnosis is likely. So first thing, you're going to see about the technique adherence, then you're going to check about the triggering factors, then you're going to check that whether is there any possibility for the alternative diagnosis or not. And that alternative diagnosis could be anything: cystic fibrosis, any bronchiolitis, any other thing, right? So if it is so, you're going to coming to the next step now, that refer the child to a specialist in asthma care if none of these explain treatment failure. Like if there is a problem with the inhaler technique adherence, you are going to counsel them, you're going to show the technique, you are going to refer to the nurse, okay, to explain them. If there are triggering factors, you are going to stop those triggers. If there is alternative diagnosis, then you are going to treat accordingly. If none of them is present, okay, then you're going to refer the child to a specialist in the asthma care if none of these explain treatment failure. Okay, so this is the way how you're going to go through it, right? Now, this was if symptoms do not resolve during trial, right? If symptoms resolves during trial, that means that this is being an effective therapy, okay, and that means that symptoms are being controlled on this, so you're going to continue this treatment. Okay, so consider stopping ics and saba treatment after 8 to 12 weeks and review symptoms after a further 3 months. Now this is a change in the guideline, because previously it used to say that continue the treatment for the further, but now here they say that if it is being control on these things after 8 to 12 week trial of this medicines, you are going to stop them. Okay, you are going to stop them and look them for the 3 months. So you are going to assess them for the further 3 months, that whether the symptoms are there or not. Okay, so if there is no symptoms, then there is no need to give the treatment. Okay, if the symptoms reoccur, that means the symptoms are reoccurring after stopping this treatment, so that means that they need this treatment, right? So if symptoms reoccur after reviewing them 3 months, or acute episode requires systemic corticosteroid or hospitalization, that means they are being uncontrolled, then you're going to start the treatment again. So restart regular ics, which is the inhaled corticosteroids. Okay, begin at a pediatric low dose. So first you're going to start with the low dose which you started before, and then if it is not being control on that, if needed, so they can be switched up to the moderate doses. Okay, so titrate up to pediatric moderate doses if needed, along with the short acting beta agonist. Okay, so any questions up till now over here? Okay, now what will happen, that you're going to, they say that once you have restarted this medicine and titrated up to the moderate dose of the ics with the saba, now what you're going to do, that you are going to do a further trial of treatment trial. When? Yes. Somebody wants to say something. Okay. Okay, so yeah, so where I was, yeah, so they say that you have to consider off trial treatment again, off treatment trial again. So what is that thing, that you are going to restart the treatment, okay, review the child within 12 months, that how they goes, okay, and after 12 months you are going to again stop the treatment for 3 months. Okay, so consider a further trial without treatment after reviewing the child within 12 months. Okay, so if they are obviously well controlled, okay, even after the treatment has been stopped, then there is no need to continue the treatment. Okay, so if the symptoms reoccurs after 3 months, then you are going to carry on with the treatment again. Okay, so you are going to restart the treatment. All right, now the question is, now this is not been explained so well in this, okay, but they have given this thing in the nice guideline. Okay, that after this reviewing, you are going to continue on this, right? And now if they are uncontrolled, if the asthma is uncontrolled on the pediatric low dose, and which is titrated up to the pediatric moderate dose, then you are going to add up the ltra. So consider an leukotriene receptor agonist in addition to the ICS for a trial of 8 weeks to 12 weeks, then stop if ineffective or side effects are there. Okay, with a short acting beta agonist, right? So I'm mistaking over here. I think this is leukotriene receptor antagonist, not agonist, right? Okay, so yes, so consider an LTRA in addition to the ICS for a trial of 8 to 12 weeks, then stop if ineffective or side effects. So the step which we did previously also, that you have to add up the LTRA for 8 to 12 weeks, okay, and then you have to see the response. If it is ineffective and side effects are there, you have to stop it. Okay, if it is responsive, then you have to continue it. Okay, if the asthma is uncontrolled on this thing, okay, then you have to stop the LTRA and refer the child to specialist in asthma care for further investigation and management. Okay, so this was the guideline for the children for the management of asthma under 5 years of age. All right, so if you have any questions you can ask me. So we move towards,
Madam, for children above 5 years, simple is
yes,
that we have to start LTRA first. If MT the combined therapy is not available, then we start LTRA first. Then we will increase the dose to moderate dose. But below 5 years, the moderate dose is done first. Then we add LTRA if the symptoms are not controlled.
yes, yes. But if
Yeah,
you can
like
see
this.
over
Okay.
here, there is there is a specific criteria they have given this time, not only the names that we are going to top up with this or top up with that, but they have given a specific criteria that we have to see, we have to give LTRA for a trial of 8 to 12 weeks, okay, and then we have to see whether it is responsive or not, and then we are going to either stop or not. Okay, so here you can see that they have mentioned that stop the LTRA. Okay, but in over here they have say that if it is ineffective and side effects are there, then stop it. Okay, if it is responsive, then carry on. And if the asthma goes uncontrolled, then you have to continue the LTRA as well. Okay, but you have to add the elaba also. So that is the reason they have given with or without an LTRA. Okay.
Yeah.
Okay. Another question we have, second trial is for 12 months. No, second trial is not for 12 months. Second trial is also for 3 months, but they mean to say that once you have restarted the treatment, review the child for 12 months at least, and then give a second trial for 3 months. Okay, so coming back to that, let me read that. Consider a further trial without treatment after reviewing the child within 12 months. Okay. All right. Shall I move to the next one?
Yes, yes.
Okay. Okay. So the next one we have is the post exposure. If you can see, right? Post exposure prophylaxis for varicella or shingles. Okay, so this is an important guideline for FOP exam. A lot of questions are there again related to this. And again, I would say that previous questions are the ones which are related to the previous guideline. Now the guideline has been changed, so we are not going to discuss whole of the guideline related to this, because a specific part has been asked regarding the post exposure prophylaxis, that when to give and when to not, when to give the immunoglobulins and when to give the acyclovir. Okay, so there is a specific guideline for the neonates and infants. We are going to discuss about that. First, I would like to tell you that to whom it's recommended to give the post exposure prophylaxis for varicella or shingles. Okay, so you might know that what is varicella. Varicella is a chicken pox. Shingles are those one who has already chicken pox in their body, and if they become immunocompromised, or after some time, shingles can appear in a nerve root. Okay, the eruptions can come in them, and which are common in the immunocompromised. So this is known as the varicella or shingles. Now, post exposure prophylaxis is recommended for individuals who fulfill all of the following three criteria. So three criteria are significant exposure to the chickenpox, varicella, or shingles, which is the varicella zoster, during the infection period. If they are at increased risk of severe chickenpox, such as if they are immunosuppressed. Okay, so the diseases like HIV, or if they are taking certain steroids for longer courses, longer periods. Okay, some neonates and susceptible pregnant women. Okay, another is no antibodies to varicella zoster virus is present in their blood. Okay, so for this we need to do the urgent testing of the varicella zoster virus antibody. So urgent varicella zoster virus antibody testing can be performed within 24 hours, and depending on them we decide that whether the child is immune or not, and then we are going to further treat the child. So there is whole criteria and guideline for that. Initially it was something else. Now they have provided this chart on their website, a government of UK, which you have to follow, and this is very important change, you should know. Okay, so guidelines on post-exposure prophylaxis for varicella or shingles. We have just a second. Yeah. Okay. So first, we are going to discuss about those neonates whose mothers develop chicken pox but not shingles. Okay, we are not talking about shingles over here. So neonates whose mothers develop chicken pox in the period 7 days before the delivery and 7 days after the delivery. So that means if the child is going to born and if the mother has antenatal chicken pox 7 days before the delivery and 7 days after the delivery, what is the criteria of testing and what is the criteria of the management? So if this thing happens, that if it is 7 days before and 7 days after delivery, so testing is not required for the mother or infant. Okay, so no, uh, not required for mother or infant, testing is not required at all. You have to directly start the treatment. Okay, so treatment with IV varicella immunoglobulins or IVIG should be administered as soon as possible following exposure, ideally within 96 hours. Okay. In addition, commence IV acyclovir as soon as possible following exposure and for a minimum of 48 hours. Thereafter, an oral switch can be considered. Treatment should be continued until 21 days. Okay. So, chickenpox in to a mother of a neonate, if it is appearing 7 days before and after, so no need to testing. You have to give the IVIG also, you have to give the IV acyclovir also, and then you have to switch the IV acyclovir to the oral acyclovir. Okay, and that should be this should be administered within 96 hours. IV acyclovir should be given as soon as possible, and that should be at least for 48 hours, and then after 48 hours the IV should be switched to the oral treatment, and this whole treatment should be continuous until day 21. Okay, so these are the important points you have to remember for this. Another thing is, if infant under 1 year who have remained in hospital since birth within any of the following. They are talking about the immunocompromised children over here, actually. So they have given certain criteria in which you have to look for these. Okay, so born before 28-week gestational age or weigh less than 1000 gram at birth, or infant who have severe congenital or other underlying condition that require prolonged intensive or special care during the first year of life. So these 3 to 4 conditions they have given, in which they have said that infant under 1 year who have remained in the hospital since birth, like they are having certain chronic illness, or they have been in the hospital, have been immunocompromised. Okay, so in such children you have to test VZV antibodies, which is the varicella zoster virus antibody status in the infant only. Okay, so remember the point. So for infant under 1 year who is susceptible, you have to check the antibody status in the infant only, and depending on the status, you are going to treat the child. Okay, so if found to be antibody negative, now if the antibody is positive, so the child is already immune, there is no need to give any prophylaxis. Okay, but if it is coming negative, if it's found to be VZV antibody negative by a qualitative assay, or it is less than 150 by a quantitative assay, then what you're going to start with, you're going to start oral acyclovir or valacyclovir should be started from day 7 post exposure. So that means after post exposure, start from day 7 and continue for 14 days. So start from day 7 post exposure and continue to 14 days. So important things over here is that testing should be done in infant only. If it is less than 150 or negative, then you have to give the oral acyclovir or valacyclovir from the 7-day post exposure and continue for 14 days. Then another group is neonate exposed to chickenpox or shingles other than in the mother in the first 7 days of life. So here we discuss about the mother, that whether if the mother is had antenatal chickenpox or postnatal chickenpox. Here, if the neonate comes in a close contact with the chickenpox other than mother, then what you're going to do? Okay, so neonates exposed to chickenpox or shingles other than in the mother in the first 7 days of life. For infant whose mother have a history of chickenpox or shingles or 2 doses of varicella vaccine, assume that they are immune. So up till here I have read. Okay, so this means like those mothers who have already have a history of chickenpox, so obviously they will be having antibodies in them, and that must have been transferred to the child as well. Okay, just give me a second, my charger has uh, okay, yeah, sorry for the inconvenience. Okay, coming back to our topic. So those mothers who have already experienced chickenpox, so they are already immune and they might have transferred the antibodies to the neonate. So assume that they are immune, or the mothers have already have the 2 doses of the varicella vaccine, so you have to assume them immune as well. Otherwise, if none of these are there, like mother doesn't have any history of chickenpox and mother hasn't have the vaccines as well, so you have to test either mother or the neonate. So preferred method, they say that test the mother, okay, rather than neonate. So you have to test them. What you're going to test the mother, again you have to test for the VZV antibody, varicella zoster virus antibody. So if found to be VZV antibody negative, again by a qualitative assay, or if it is less than 150 by a quantitative assay, so the same thing you are going to apply is the oral acyclovir or valacyclovir, should be started from day 7 post exposure and continued for 14 days. Okay, so this is repeated over here, just the difference is that here you are going to check the infant only, okay, but here you have to see that whether the mother is immune or not. Depending on that, you have to check the antibody levels of the mother and then decide that what to do. All right, so do you have any questions regarding this guideline? Okay. Okay, so
So,
shall I move?
madam, the only indication for immunoglobulin is the mother who had chicken pox within a period of 7 days before or after
And
delivery, right?
yes, yes, otherwise you are just going to give the oral acyclovir. Okay.
In third
Yeah.
scenario, if it is mother, other than mother, means it's different mother or same mother.
No, other than mother means that it could be a brother, any relative, any outsider. They mean to say that. Suppose the neonate is born to a mother, right? So mother is fine, but neonate has been exposed to someone else in the room or anywhere in the house. That could be a brother, sister, any friend, any relative who had a chicken pox and comes to a contact to a neonate. In that case, you are going to check the mother status. Why? Because they had already antibodies in them and must have been transferred into the neonate. So you have to check the immunity basically.
Okay.
Am I clear? Right.
Yeah, clear, clear.
Okay, thank you. Okay, so I'm moving forward then.
If a neonate presents at 20 days of life with varicella lesions at that time, what should we do? Like
So
around
no,
20 to 20.
and yeah, so in that case, prophylaxis is not given. If the child is not immunocompromised and if it's a simple contact, then no, it shouldn't be given.
If baby is symptomatic, the whole baby is having lesions of varicella at that time,
Ye-
baby is having fever.
Like if they are developing, because this is we are talking about the prophylaxis. Okay, so if they are developing the chicken pox, then you have to treat accordingly. Then obviously you are going to give the acyclovir, and that is a separate guideline for that.
Okay, thank you.
Okay. Okay, now we are done with the prophylaxis. Okay, now we are going to talk about the diabetic ketoacidosis. So there is no recent changes in diabetic ketoacidosis in 2025 and 2024. It has been changed in 2021, but all the books have the previous one. Okay, even the one which is given in the 2022 and 2024 has some you can say has some confusion to understand. Okay, children do student do confuse themselves regarding the bolus solution and amount of it. Okay, so that is the reason I am going to discuss about the diabetic ketoacidosis, because a lot of question comes related to this. Okay, So diabetic ketoacidosis, you have to, we are going to go through whole of the guideline, and that what you are going to do, because each of them, like each topic has its own question, like about the bolus also, about the maintenance fluid also, about the sodium levels also, about the potassium also. Then we are going to talk about the glucose also. So one by one we are going to discuss that, right? So diabetic ketoacidosis, we have to assess the severity of the diabetic ketoacidosis. So depending on the acidosis, we are going to discuss that whether it is mild DKA, moderate DKA, or severe DKA. So when we talk about mild DKA, moderate DKA, or severe DKA, we mean to say about the pH and the bicarbonates. So pH 7.3 or bicarbonate less than 15. Moderate DKA is pH 7.2 or bicarbonate less than 10. Severe DKA pH less than 7.1 or bicarbonate less than 5. Okay, so this was the severity of DKA according to the acidosis. Okay, now severity of DKA associated with dehydration, because the severity of the DKA depends that how much dehydration they have. Either they are clinically dehydrated, no dehydration, or shock. Because previously it used to be mild, moderate, and severe dehydration, but for the RCPCH we have clinical dehydration or shock. Okay, so those who are mild to moderate DKA, that means those who falls in the pH 7.3 to 7.29. Okay, so they are considered clinically dehydrated. That means they have 5% fluid deficit. Okay, severe DKA, which falls below 7.1, which is pH less than 7.1, they are basically 10% fluid deficit. Now there are certain features of the clinical dehydration and shock which you should know, and that is a chapter related to the gastroenterology. Like clinical dehydration will not be having that thing, CRP, that is the capillary CRP less than 2 seconds. Okay, but in shock, in severe DKA, which is the 10% fluid deficit, the child will come up with the tachycardia, tachypnea, and the capillary refill time will be CRT, sorry, the capillary refill time will be greater than 2. So you mean you will see that whether the child is in shock or not. If the child is in shock, then that means there is 10% fluid deficit, and if if they are only clinically dehydrated, then that means there is 5% fluid deficit. So depending on them, you are going to decide that what type of bolus should be given, what type of fluid should be given, how much it should be given. So that is an important thing to remember in FOP exam, right? So when you have already assessed the severity, you have already assessed that whether it is 5% fluid deficit or the 10% fluid deficit, right? You are going to select the bolus. Okay, so here you have to see that if it is severe dehydration, DKA, and there is 10% fluid deficit, you are going to go with 10 ml per kg over 30 minutes, zero point 0.9 sodium chloride. So you are going to give the 0.9 sodium chloride, which would be 10 ml per kg over 30 minutes. Okay, so in the guideline, in the bedside guideline 2022 to 2024, they have mentioned about the 20 ml per kg. Okay, so that is not correct actually, because the guideline says that you shouldn't give 20 ml per kg straight away. Okay, because there is a risk of fluid overload in DKA. So first you are going to give the 10 ml per kg over 30 minutes, zero point 0.9 sodium chloride. Then you are going to assess the child. If still there is a dehydration, you are going to top up again, repeat 10 ml per kg again if required. Do not subtract this from total fluid requirement. Okay, so I have a question. Yeah, so we are going to give the bolus basically when the child is on shock. Okay, so 10 ml per kg over 30 minutes, zero point 0.9 sodium chloride you're going to give. Then you have to assess them, and if they are still dehydrated, then repeat 10 ml again if required. And if there is 10% fluid deficit, so whatever bolus you are given, you are not going to subtract that from the total fluid requirement. So you have to remember this point. Okay, another scenario is mild to moderate DKA, only 5% fluid
Sorry,
deficit is
madam.
there. Yes.
Sorry. Maximum here in severe dehydration, how much we can go? Till 40 ml per kg?
Yes, 40 ml per kg they have given. Yes.
So 40 ml per kg over 2 hours, that will be 30
Yes.
minutes, right?
Yes. Yes.
Okay.
Okay. So mild to
They
moderate.
they said that Initially, they said that substitute fluid, right?
Yeah, initially they used to say that subtract the fluid, okay, but now they say that if the child is in shock, okay, then you do not need to subtract it from total fluid requirement. Okay. Another scenario is mild to moderate DKA, 5% fluid deficit. Okay, so it is 10 ml per kg, 0.9 sodium chloride over 30 minutes. Okay, subtract from total fluid requirement. All right, so now if it is 5% fluid deficit, then you have to give 10 ml, the same thing, all right, over 30 minutes. But this fluid, you are going to subtract this fluid from total fluid requirement. Okay, so there is a difference over here, right? So 10 and then reassess, then 10 until the dehydration is sorted out. You can go up to 40, and over here you are going to give the 10 ml, and that this fluid you have to subtract from the total fluid requirement. Now this is the bolus. Now we are going to talk about the maintenance fluid, which we are going to start. So before starting the maintenance fluid, that how you're going to calculate it. Okay, so calculation of total fluid requirement for maintenance. So total fluid requirement equals to the fluid deficit and maintenance fluid. So there is a formula for this calculation of the fluid deficit. So you are going to calculate the fluid deficit first. So if it is severe dehydration, so 10% fluid deficit. If it is mild to moderate dehydration, then 5% fluid deficit. Okay, so you will put 5 over here if it is 5%, you will put 10 over here if it is 10%. Okay, the formula remains the same, weight in kg into 10, and then you are going to multiply whatever will come, you are going to put in the fluid deficit, right? Then you are going to calculate the maintenance fluid. So this is a very normal casual formula which we use for the maintenance therapy: 100 ml per kg per day for 1 to 10 kg, okay, and then 50 ml per kg per day for 10 to 20 kg, and 20 ml per kg per day for each kg above 20 kg. Okay, so if you do not know that what is it, you can ask me, otherwise it's very common thing. Okay, so you are going to calculate the maintenance fluid, and you are going to put over here. Okay, now the thing is subtracting the bolus. Okay, so if it was 5% fluid deficit, then you are going to subtract the bolus from the total fluid requirement. Okay, and if it is was the 10%, then you are not going to subtract that fluid. So whatever the fluid requirement comes, you are going to start the maintenance fluid of it. Okay, so this is the way how you're going to calculate the fluid, right? Now, what type of fluid should be started? This is one of the exam question, that what you start first and what you start later. So basically, you are going to start with 0.9 sodium chloride. Okay, this is a starting maintenance fluid, along with the potassium chloride, 20 mmol per 500 ml. So because you are going to start the bottle of 500 ml of sodium chloride, right? So each of them will be having 20 mmol potassium chloride. If it is 1000 ml, then it should be 40 mmol normally, right? So depending what you have in the exam question, I think in the recent exam also they have asked this. All right, so 0.9 sodium chloride along with the potassium chloride is the starting maintenance fluid you are going to start. Before that, you have to, like, when all of this is going on, you have to monitor the everything, like I have mentioned here, that monitor blood glucose, urine output, input, neurological status 1 hourly for the cerebral edema, monitor electrolytes, like potassium, sodium, blood ketones after 2 hours, and then 4 hourly. So all the monitoring is going on. Okay, so you have to see whether the potassium is on level or not, because there is a risk of the hypokalemia also, and there is a risk of the hyperkalemia also. Okay, so this thing is for those when the potassium is 3.5 to 5.5, right? So sodium chloride 0.9 with potassium chloride 0.3, that is 20 mmol 500 per ml, right? So this is for 3.
Sorry,
Yes.
doctor. The previous slide, is that 10, what 10? 10 hour or what? Previous
uh,
slide, sorry.
what you are
Previous one, يعني 5% time weight per weight time 10. What 10? Not this slide, last one.
last one. Okay, let me come through it.
Sorry.
Okay, which
Here, yeah.
yes,
5% fluid deficit, 5 time weight in kg time 10. This 10 what?
this one you are talking.
Yeah, 10. This 10.
Yeah. Yeah, so subtract the bolus from total fluid requirement if 5% fluid deficit was there. So in the previous slide, like I mentioned,
Yes.
over
No,
here,
I mean here. No, sorry. This I mean this 10. 4 here in 5% fluid deficit. Correct by 5 time weight time 10.
yes, 10 is the constant for the formula. You are asking about this?
Yeah.
Yeah, so this is a constant formula basically. So this is the calculation of fluid deficit. The formula is you have to multiply the fluid deficit into weight into kg into 10 to take out the fluid deficit.
Sorry,
Okay.
sorry. Sorry again. Sorry. I
Okay,
didn't
so
hear.
this is a
Mm,
constant formula, okay,
yeah.
and whatever fluid deficit is there, you're going to multiply by the weight in kg of the child, okay, and then you have to multiply by 10 to take out the fluid deficit.
Multiply by
How
10 again.
we will
Yes,
Okay.
calculate deficit?
yes,
Mm,
okay. So this is constant, right?
أيوة. Okay, طيب. Thank you. Thank you.
Okay. Okay. So coming back to our next slide over here. So where were we? So for potassium 3.5 to 5.5, we have to start the KCl 20 mmol per 500 ml. Then after starting this fluid, you are not going to start the insulin at the very start. You have to wait for some time, at least for 1 to 2 hours, because when we start the potassium, the glucose levels also falls for for to some extent, right? So that is the reason they recommend start insulin infusion, and that infusion should be 0.05 to zero point 0.1 unit per kg per hour after 1 to 2 hours after starting the hydration. Like you have to add up this into this, but after 1 to 2 hours of starting the maintenance fluid. Okay, then you are going to check like this fluid deficit over should be given over 48 hours, and maintenance fluids over 24 hours, that you have to calculate and give. Okay, so because we are giving two things, we are giving fluid deficit also, and we are giving the maintenance fluid also, and that will make a total fluid. All right, and you are going to, because when you calculate the fluid, you are going to um, multiply and divide to make it per hour thing. Okay, so when you are going to divide them, so you are going to divide by 48 for the fluid deficit, and you're going to divide maintenance fluid by 24 hours, so to make it per hour. So whatever fluid comes in a per hour, you are going to start this thing. Okay, so this has not been asked in the exam, in FOP exam, but just to make you know that how it goes, only the type of fluid they usually ask you. Okay, so monitoring should be done when you start the maintenance fluid. So monitor blood glucose, urine output, input, neurological status 1 hourly, monitor electrolytes, blood ketones after 2 hours, and then 4 hourly. Okay, all right. Then after this, you are going to assess the potassium also, because the monitoring is going on. Now we are going to talk about the potassium levels before hydration. We are going to start. So the potassium level should be below 5.5. Okay, and urine output should be there. So this is a recommendation. All right, otherwise the guideline says that if it is greater than 5.5, then you have to seek the senior advice. Okay, and if it is less than 3.5, then you have to add more kcl, which will be 40 mmol per 500 ml. Okay, so depending that what potassium levels are there. All right, now coming to the sodium levels and neurological status, so we have to keep
Hello,
an eye for
excuse
this.
me.
Yes.
Yeah. If the potassium level is less than 3.5 millimole, then we have
Mm-hmm.
to add 40 millimole per 500 ml, right?
Yes.
And
Yes.
starting off insulin, is it not like that? Means initially we have to give the potassium NaCl plus KCl up to 250 mg per kg, 250 mg per dl.
No,
Uh,
it's here.
it's
Okay, so
out now.
20, yes, it's 20 mmol per 500 ml. Okay, for 3.5 to 5.5, considering it's normal, this is the starting one. Okay,
No, starting of the insulin.
starting of the insulin. This you're talking about 0.05 to zero point 0.1. This is you have to consider 0.05 to zero point 0.1 unit per kg per hour. This is the only thing you are going to carry on. It has nothing to do with the potassium levels. Am I getting you clear? Like am I getting you correct or not? You can repeat what you are
They
asking.
said that means in Indian textbooks as well as guidelines, they said that when the sugar level falls from, for say example, 600 or 500 up to 250, you have to give the NaCl plus KCl. So once it reached the 250 mg, then we have to start the insulin. Till that time, we have to give just fluids.
No. It's after 1 to 2 hours after starting the dehydration. After starting the hydration.
Okay,
Okay.
thank you.
Ma'am, I have
Thank you.
one doubt. This maintenance fluid is over 24 hours, or that also with 48 hours we'll get the total ml per hour? Like
Uh,
maintenance
fluid
fluid is over 48 hours, na? Like we
fluid
calculate for best pet guidelines and this also for 48 hours we calculate, na? Matlab together. Maintenance
maintenance
plus
fluid
deficit.
maintenance fluid over 24 hours and fluid deficit over 48 hours. So this is recommendation in the guidelines. So suppose if I give you an example, like if suppose any number like 100 is the fluid deficit, okay, plus maintenance fluid is also 100, suppose. Okay, so to make it per hour, you are going to divide this 100 to with 48. Okay, and you're going to divide this maintenance fluid to 24 hours. So whatever comes, okay, you are going to add them, and this will make whatever number come per hour. So this is how you're going to calculate. But I have rechecked this: fluid deficit over 48 hours and maintenance fluid of over 24 hours.
Okay, thanks.
Okay.
One more question, excuse me for that.
Yes.
Initial, when the starting of the decay, if the dehydration is more, then there is a chances of hyperkalemia. That
Yes.
is, the potassium level is 5.5 millimole. Then,
Mm-hmm.
shall we wait for adding the KCl or what?
Yes, so if it is great, here I told you, right, that before starting the hydration, you have to check the potassium levels. It should be below 5.5. If it is not below 5.5, then you have to seek the senior advice.
Okay, okay, okay.
Okay. All right.
Yeah.
And urine output should be there also. If there is a problem of the urine output, then also you're not going to give the hydration.
Ma'am?
Urine output.
Yeah, okay, okay. Thank you.
Okay,
Thank you.
no problem. Okay, now coming to the sodium levels. So you have to keep an eye for the sodium levels also. So there is a chance that there is cerebral edema because of it. The fluid overload could be there. There is osmotic diuresis. So a lot of questions are there related to this in TAS exam regarding its mechanism. Here I'm just going to talk about the guideline. Okay, so you have to because you are checking the neurological status as well, uh, just to make sure that they are not developing any signs of cerebral edema. So the signs you are going to check is the headache, irritability, reduced consciousness level, hypertension, slow heart rate, and altered breathing. Now this is a Cushing triad: hypertension, slow heart rate, and altered breathing. If these are present, that means there is a sign of cerebral edema. Okay, so if these signs are happening, so this is a medical emergency and you have to stop the fluid. Okay, you have to make sure that this is not hypoglycemia, and the type of fluid you are going to give is the 2.7% sodium chloride, which is the hypertonic saline, or another is the mannitol. So both of them has been mentioned in the guideline. Okay, the best one, they say that you should give the 2.7 sodium chloride. Okay. Okay. Can you mute yourself? Only open your mic when you want to say something. Okay. All right. So, yes, coming back to it. So, exclude hypoglycemia. You have to give the sodium chloride hypertonic saline or mannitol. The best one is the hypertonic saline. If it's not present, then mannitol should be given. Whatever is present, so you shall give that. Senior help should be taken, and fluid restriction is done to 50% if cerebral edema is developing. Okay. So, this was regarding the sodium levels in the cerebral edema. Now coming to the blood glucose level, that how you're going to assess the blood glucose level, what you're going to do if the blood glucose level is falling, at what levels you are going to do what. Okay, so two things I will discuss over here. Okay, so when blood glucose, because in DKA, the usual blood glucose levels are two-way high, like 15, 16, could be 20. Okay, when blood glucose level decreases less than 14 mmol, okay, then you have to add 5% dextrose. Initially, we started the sodium chloride, okay, and we started the potassium chloride, okay. Then we add the insulin, okay. Now if the glucose is falling, then you have to add the dextrose into it, okay. So add 5% dextrose to the rehydration solution and reduce insulin from zero point 0.1 unit to 0.05 unit, okay. So you have to reduce the insulin once it is coming below 14 mmol, right? So you have to decrease the insulin, okay, and you have to add the 5% dextrose to the solution, okay. When blood glucose level decreases to below 6 mmol, okay, so now you have to change this 5% dextrose to the 10% dextrose solution, okay. So change 5% dextrose to 10% dextrose solution. You are not going to further reduce the insulin, okay. So you are not going to further reduce the insulin from 0.05 unit, or you are not going to stop the insulin, right? If ketones is still greater than 1, do not reduce insulin below 0.05. So you have to make sure that for reducing the insulin, there should be negative ketones. If ketones are still coming greater than 1 mmol, then you do not need to reduce the insulin below 0.05. Okay, so for blood glucose level less than 14, add 5% dextrose, shift zero point 0.1 unit to 0.05 unit. This is for insulin. If it is less than 6 mmol, then change 5% dextrose to 10% dextrose solution, okay. Another thing is DKA resolution. Now we have discussed about the bolus, maintenance fluid, we have discussed about the potassium, sodium, we have discussed about the glucose, insulin therapy. Now we are going to talk about the DKA resolution, that what you are going to do. You have to assess the child. Child is clinically well, taking oral fluids orally without nausea and vomiting. Ketosis resolve, which is less than 0.6, is negative, okay. pH is 7.3, that there is no more acidosis. Okay, now you're going to stop all the solutions you are giving. But how? Okay, so start subcutaneous insulin. Like if the child is on subcutaneous insulin, so start subcutaneous insulin 30 minutes before stopping the IV infusion. Okay, and start insulin pump 60 minutes before stopping IV infusion if the child is on insulin pump. Okay, so this is a DKS resolution, how you're going to stop the IV therapy, right? So am I clear so far? If you have any questions for diabetic ketoacidosis. Okay, so we have
मैम
covered.
फ्लूइड डेफिशिएट का बता दीजिएगा प्लीज
Sorry, yes. What you want me to ask?
फ्लूइड डेफिशिएट हम कैसे निकालेंगे हम कैसे कहेंगे 5% फ्लूइड डेफिशिएट है 10%.
Yes, okay, let me show you. Depending on the clinical criteria, okay, you are going to assess that. Either like in questions, either they will mention you the pH status, okay. Depending on that, you are going to assess that is it 5% or 10%, okay. Or either they are going to mention you about the dehydration status. Like if it is clinically dehydrated, that means they are not in shock, then that means that this is 5% fluid deficit,
आगे
okay. And
पीछे हो सकता था इधर से
if they are clinically shocked, that means they are tachycardia, tachypnea, okay. There is hypertension, the capillary refill time is greater than 2 seconds, the child is going in shock, so that is 10% fluid deficit, okay. Okay, hello.
Yes,
Okay, so yes, okay, so our session is and ended up till here. So we have
Ma'am,
discussed
excuse me.
major guideline.
This is
Yes.
about the this asthma treatment. That means the guidelines below 5 years of age. The again question was about the trial.
Okay.
I didn't get the
Just
trial actually.
okay. I'll repeat that. Just give me a 1 minute. I'll be back. Just 1 minute, please. Hello. Okay.
Yeah.
Sorry for the inconvenience. Yeah. So coming back to the trial, the under 5 one or 5 to 11 one.
Under 5, both, ma'am, both. Actually, it
Okay.
is little bit confusion, that's why.
So which trial you're talking about? This one?
Yeah.
Okay.
Yes.
So
Yes.
okay, so consider ICS and SABA treatment after 8 to 12 weeks and review symptoms after a further 3 months. So if the child, like we are giving the trial of the pediatric low dose ICS for 8 to 12 weeks, right? And then we are going to stop the treatment over here, and then we are going to assess the child that whether the symptoms are reoccurring or not. All right, so consider stopping ICS and SABA treatment after 8 to 12 weeks and review the symptoms after a further 3 months. So after 3 months, you are going to assess the child that whether the symptoms are reoccurring or not. Okay, so you are going to stop the treatment for 3 months after giving 8 to 12 weeks. After giving the treatment 8 to 12 weeks, okay, then you're going to stop the treatment, then review the child for 3 months for the symptoms, that whether the symptoms are reoccurring or not. Okay, so if the symptoms are reoccurring after review or acute episodes require systemic corticosteroids or hospitalization, then you have to start the treatment again. That means you are going to start the pediatric low dose again, and if it is not controlled on that, so you have to titrate up to the moderate dose. Okay, now it's clear.
But doctor,
Yeah,
now we
we
didn't
have.
follow this.
Yeah, means we have to we have to wait for 3 months. We have to review in between that, and then
Mm-hmm.
again, if the symptoms occur in terms of acute admission, hospitalization, or systemic steroids, then we have to again restart with the low dose to moderate dose of ICs. Then after
Yes.
that, how we move further?
Okay, how we move further is that we are going to assess the child, like when the child is on the moderate dose, pediatric moderate dose. So they should be on the moderate pediatric dose for the 12 months period. Okay, and you have to see the child that time. Okay, so if they are controlled, then you are going to again give a trial for the off treatment trial for the further 3 months. Okay,
I'm little
if
bit confused for the 12 months. Means we have to give the trial for 12 months, total 12 months, means 1 year.
No, trial is not for the 12 months. The treatment is continued till 12 months. Okay, the trial will be for 3 months only. Consider a further trial without treatment after reviewing the child within 12 months.
Okay, means we have to wait, means we have to review child, means we have to look for the child for 12 months. In between, if the symptoms reoccur, then we have to give the trial for 3 months.
Yes, of treatment trial months. Like we have to give the treatment for 12 months. Okay, and if the child remains control on that treatment, then again you are going to give a trial without treatment. So give the trial for without treatment. Okay, then you have to assess the child that whether the symptoms are reoccurring or not. If the symptoms are reoccurring, then restart the treatment. Okay, I know this is a bit confusing. In the NIC guideline, they have used the same statements.
Okay, okay.
Okay, yeah. Okay, Dr. Taya, I will ask my admin if the PDF slides can be provided to you or not. Okay. So, okay. Um, I hope the guidelines are clear to you now. These are very important updates of the guidelines which you should know before appearing to the exam. And I hope you will ace it. And if you have any further question, you can ask me.
Excuse me, this is the question little bit different. What should be the last minute or 11th hour means preparation?
Okay, so last minute
Notes,
preparation. When is your
lectures,
exam? When is your
25th,
exam?
25th of June.
25th of June. Okay. So last minute preparation, like what you can do, like it won't be called as a last minute preparation, but lastly, what you can go through the recalls, go through the topics, okay, and the main points of it. Just try to, revise the thing again and again. Okay, so it will help you.
So
Okay.
I was thinking about going through all the lectures because it contains a whole information.
If you can go through, so it's very good. Revision is very important. You have to go through definitely. But as you asked me about the last minute ones, okay, so you can just give a quick read for everything.
quick read
Yeah.
as well as means last
Okay.
means I want to ask means last hour means it is about 5-6 days before we should go again and again recall
So it
or
depends that how much you are, see
prepared we are.
how you are going to revise it. You are going to revise, like, this is for the course students. You are going to revise in a way that go through the recalls and those topics from the lecture. Okay, so this is the way how you're going to revise it.
Okay, thank you.
Okay, thank you. Okay, Dr. Julekha, the changes again of the diagnosis of asthma. The recording will be provided to you, so you can go through the recording, because it's not possible for me to repeat the whole thing. Okay, so I will ask my admin to give you the recording so you can go through that. Okay. And if you don't understand anything, so you can ask me. You can do the personal message as well. All right. Okay.
Thank you.
Okay. Thank you so much. Thank you everyone for attending the session. Okay. Have a good day.
Thank